And essentially,
Sorry, Toby.
You're fine. And essentially what happens is the vascular system and the ventricles kind of slowly accommodate and expand to accommodate that bolus of CSF. So instead of then having an associated increase in pressure, what happens is the system kind of accommodates to accommodate, that cerebrospinal fluid, and so actually the intracranial pressure doesn't increase. When we think about kind of the actual condition, we consider it as we'll talk around symptoms, but a clinical triad of a gait disturbance, urinary incontinence, and memory impairment. And as I said, it's kind of normal CSF pressure on a lumbar puncture. You might have a radiological finding of enlarged ventricles, and actually they confirm the diagnosis that someone improves after shunting. Obviously, that's what we're trying to improve, not just shunting everyone and seeing who gets better, trying to be a bit more selective and objective with our treatment. We do know that there has been some evidence that MDT assessment, so comprehensive MDT assessment and targeted specialist assessment, helps the accuracy of diagnosis. And actually earlier diagnosis can lead to better overall outcomes, which I'll link kind of to my job. That's kind of part of the reason our service has been set up. Just see whether, sorry. If we're considering about the epidemiology, I guess kind of the take home from this slide is actually that it's much more common, or it's understood to be more common than actually was initially suspected. Anderson et al. This was quite a large review in Sweden in 2019, and they looked at kind of basically a group of older patients. I think they had over 1,000 participants, and kind of almost screened everybody and looked at the symptoms they had, and actually the prevalence when they did scan the people who had possible normal pressure hydrocephalus, actually scanned them. And what they found is actually the prevalence of the condition was up to 3.7% in adults over 65 years. And actually that prevalence was 4 times higher in the patients who are over 80 compared to the patients between 65 and 79. I'm based, as I said, in Cambridge, Addenbrookes Hospital, but so if we kind of extrapolate that to the east of England where I work, that's up to 44,000 people that prevalence would cover. Now, some of this data we have to take with a bit of pinch of salt, because there is some of these figures vary a bit in the literature, but I think the take-home message is it is more prevalent than we actually once suspected. There isn't a particular variation between males and females, and I guess also if we consider that the population overall is aging, we probably can expect these figures to be higher if this was repeated kind of several years down the line. It's the most common form of hydrocephalus in adults, and I guess they talk about a significant cause of possible reversible dementia amongst older adults. They term it to be reversible, and we see our patients improve, so they can improve and change. But when we talk a little bit around the pathophysiology, we'll also talk around kind of what exactly we mean by that. The other thing, I guess, the other big point from this slide is that actually other big reviews when they look at the condition, it's actually quite undertreated. So figures as low as they reckon about 20% people who've actually got normal pressure hydrocephalus symptoms maybe get the right treatment. So that's kind of our, I guess, our question, and what we're trying to develop is actually we've got a condition that we think is more prevalent than we initially thought, and actually at the moment it's undertreated. I don't know about you guys either, but I think in my career, kind of prior to starting this job, I'd only ever treated, I think maybe 3 or 4 patients actually with normal pressure hydrocephalus, or that I had been formally diagnosed with normal pressure hydrocephalus. And it was kind of always one of those mysterious conditions I kind of heard of a bit about, but never really then knew too much more about the management or how patients can appear. And so the pathophysiology, we'll divide this a bit into actually thinking about the underlying process, and then talk a little bit around anatomy. I guess the thing to say from both of these slides is it's still not brilliantly understood. There's been a lot more research in the last 5 to 10 years looking to kind of better understand the condition and really work out kind of exactly what's going on. But the actual flow diagram we've got here on the slide, I think, is quite helpful in kind of helping to explain a little bit more around that. There is 2 types of normal pressure hydrocephalus. So there's secondary normal pressure hydrocephalus, which would then be maybe someone who's got a baseline trauma, had a previous condition, or maybe they've got an anatomical reason that they have a difficulty with their cerebral spinal fluid drainage. But actually what we're talking about tonight is the idiopathic version, so idiopathic normal pressure hydrocephalus, which by definition means there's no specific cause. You know, we don't have it's not after a certain condition, someone's just developed it over time. Essentially, what we understand is that this is a problem, it's a vascular issue. And actually this impaired or altered compliance in the vascular system is almost the starting point for a cascade of symptoms that can cause gradual deterioration over time and this accumulation of the cerebral spinal fluid. They talk about certain risk factors for those vascular conditions, so increased age, hypertension, diabetes, other vascular conditions, so stroke. We could probably include heart disease in there as well. You have this altered vascular compliance, and then this can lead to deficient cerebral blood flow, impaired lymphatic circulation, and a loss of blood-brain barrier integrity, which can cause this, essentially, that once it starts to accumulate, it continues to do so and happens over time. The cerebral blood flow, when we look at kind of impaired or deficient cerebral blood flow, there's studies which suggest kind of there's impairments to cerebral blood flow in a wide range of areas of kind of across the brain. So including kind of the lateral and frontal white matter, the periventricular white matter, thalamus, brainstem, supplemental motor area, and actually seen more globally, as well as the basal ganglia. We'll talk this around symptoms, but I think that when we think about those, symptoms can be seen quite widespread. That's important to remember. I'm not sure if people are aware of kind of glymphatics or the glymphatic circulation, but this is a system in your central nervous system involved in waste clearance. And this exchange of solutes is driven kind of by the arterial pulsation and expansion in contraction during sleep. So again, if you have this vascular system that isn't working so well, it makes sense how the lymphatics would also be interrupted. If this happens over time, it can then also interfere with the blood-brain barrier, so it doesn't work so efficiently. And all of this can relate to you can retain these waste products as well. So it's kind of, it can start almost a neurodegenerative process on top of the cerebral spinal fluid. So it's all of these symptoms can kind of linked in together. Small vessel disease is also mentioned here on the slide. So we talk about the deficient cerebral blood flow, and actually we see some small vessel type symptoms relating to that more globally, which also link to the presentation. So this is quite a busy slide, and for that I'm sorry. But I guess kind of what I want you to take from this is it's likely that there's a combination of these things going on which are causing symptoms. We'll talk around symptoms in a moment or two, but our patients can present quite differently, which also makes it quite a challenging diagnosis for us to confirm. But because we think that there's this more kind of diffuse hypoperfusion and these more global issues happening, that's where I think we get more likely a combination of these symptoms as opposed to something one specific area and one specific problem we see. The old theories around normal pressure hydrocephalus were you've got bigger ventricles, so they've got more CSF in than they should do, and actually that they maybe stretch the cortical spinal tract a bit, and that influences the movement. But actually, on some of the studies, when we look at when the CSF is removed, it doesn't really fit. And actually, with the wide variation in symptoms, this explanation doesn't really explain kind of all the symptoms we might see. This is quite a long word. So the cortico-basal ganglia thalamocortical loops. So one of the main feedback loops to help support movement and motor function. But essentially, what we're kind of meaning here is there's subcortical influence on, so through the damage and through some of this hyperperfusion, there's influence on a subcortical level. So essentially, the feedback loops across the brain are a bit interrupted, which is why kind of we can get some of these problems with movement. And this kind of they call it almost like an apractic gait pattern. There is some associated white matter change in prefrontal and frontal lobe areas, which maybe gives us a bit of an explanation for some of the cognitive picture. And again, where we'll link that into symptoms too when we get there just a little bit later on. And the other symptom we do talk about is around incontinence and urinary issues. So this is thought to be a little bit of some problems with the central inhibition, and maybe some disruption on a corticospinal tract level, so influencing the sacral fibers. But essentially, as I said, the thing to take away from this slide is actually it's likely there's a combination of these symptoms going on as a result of this initial the initial buildup of the cerebral spinal fluid. So when we talk about symptoms, this classic triad was of symptoms of gait disturbance, dementia, and urinary incontinence was first described by Hakim and Adams in 1965. You'll sometimes see the condition also referred to Hakim's disease. There's some, within the normal pressure hydrocephalus field, there's some discussion around actually how many of these symptoms or which of these symptoms you need to be able to make a diagnosis of normal pressure hydrocephalus. So more, we talk about it as being a combination, but actually what we tend to find is often gait and balance issues are what people report first. It's been hypothesized that these are kind of the main symptoms that first present, but I think maybe through the nature of them as well, they are things that are maybe a bit more visible. Someone's aware of their deterioration in their balance, whereas maybe they have a little bit of urinary urgency and it's just something that happens, and maybe they're a bit more forgetful. So I think that's kind of important to remember. I guess when we're thinking about the symptoms, this is the clinical challenge of actually this condition. It's quite difficult for us to diagnose. So we know it's much more prevalent in patients over 60. And I guess we could all consider quite a few reasons why actually someone who is over 60 might have some issues with their walking and balance. So maybe they've got baseline orthopedic trauma, other peripheral neuropathies, age-related changes elsewhere. Maybe they've had a previous small stroke, TIA. They've got these previous issues that might also already influence their movement and balance. Again, I guess they may have some age-related change, which might influence some of their cognitive functioning. Maybe they've got another diagnosis of something else, which is also influencing that. Maybe they're just taking more medication, which might also influence some of these things. And urinary incontinence, I guess we can have things like prostate hyperplasia, urgent incontinence. So these things can coexist, and that's where sometimes I think some of these things are kind of not thought about because there's a baseline diagnosis already. Within normal pressure hydrocephalus, I guess we would be within our service. We tend to say, well, if there's at least one of these symptoms which is not explainable by all the other things we know from the past model history, then we'd consider that appropriate for a referral. But when we look at the diagnostic criteria, the quite well recognized Japanese criteria, it mentions more than one of these symptoms. So you don't have to have all three, but more than one. And as we said, there isn't really other features of another neurological or non-neurological disease to explain these symptoms. If we think about moving from possible to probable, this is where I guess we then look at more of the criteria, which would be down to assessment. So on a lumbar puncture, actually the cerebral spinal pressure is relatively normal, and the CSF content is relatively normal. And then neuroimaging might display some symptoms of ventricular dilatation. And the gait disturbance, there may be some associated gait disturbance and symptoms. And actually, if you take some of that CSF off, so you do a cerebral tap, that the symptoms improve, which when we think about the treatment going further, that I'll explain how that links to that too. Just briefly wanted to mention around neuroimaging signs. So there is kind of a growth in neuroimaging techniques. So particularly pressure contrast MRI is something we've started to use in our service, which is a way you can look at basically the pulsatility and the flow of the cerebral spinal fluid to be more accurate with your diagnosis. But particularly the Evans index is something you'll see quite commonly. Just talking about the colossal angle, that's normally seen on a coronal plane of an MRI. And essentially, the colossal angle would be the angle between the two ventricles. So if you don't know if haven't got, you can see my arrow. This kind of calculated angle here between the two ventricles. Essentially, it's deemed to be normal if it's between 100 and 120 degrees. But when the ventricles are a bit more dilated, that angle is a bit narrower. And if it's between about 50 to 80, it can be suggestive of normal pressure hydrocephalus. And there has been some studies to suggest a clinically important cutoff is any angles which are below 63 degrees, being people who should be considered for shunt. Quite a lot of people obviously won't always have MRIs we can use. So the thing I kind of sometimes do just look at is the Evans index. So that's on the transverse plane. And essentially is the maximum width of the frontal horns of the ventricles. So these two here, compared to the actual width of the cranium all the way across. This should normally be around 0.2, and sometimes even less than that. So you can see on this kind of more of a normal image, ventricles are quite small here. But actually in normal pressure hydrocephalus, it would be over a third, which is suggestion of ventricular enlargement. There is certain associated symptoms. So sometimes you can see ventricular enlargement with patients who've got global atrophy as well, but just a symptom that might be suggestive of normal pressure hydrocephalus. Just wanted to go into a couple of the other diagnostic tests that we then would do actually as part of our service. I just mentioned around the pressure contrast MRI, which essentially is a phase contrast MRI which follows one cardiac cycle. And that basically looks at how you basically have the outflow of CSF in relation to this cardiac outflow at the aqueduct level. So kind of looking if it looks at a normal level. The other thing we also do is a lumbar infusion study. So that would be a therapeutic lumbar tap. So a normal lumbar puncture and then removing up to 50 mils of cerebral spinal fluid. But alongside this tap, they would slowly infuse a small amount of fluid. And then they basically see how long it takes that newly infused fluid to then be reabsorbed. So the idea is basically you're looking at kind of that reabsorption that we tend to see is often impaired within normal pressure hydrocephalus. And they calculate this very clever figure called the R out, which is basically the CSF resistance to outflow, and kind of clinically meaningful figure there is over 10. We don't always have this actually when the patients are in. We don't get the figure straight away, but that's kind of a bit of a base figure for us to consider. I'll talk around assessment, but I guess within the lumbar taps, what we would be doing is normally seeing the patients before and after their tap, normally about 2 to 4 hours after their tap. And we're looking if there's any actual clinically meaningful changes in their gait, their thinking skills within this time period, because I guess for the diagnosis of this condition, if somebody improves when we remove cerebral spinal fluid, our treatment would be thinking about shunting. So putting in something that can remove some of that cerebral spinal fluid all of the time. So if we remove some cerebral spinal fluid as an assessment and they get a bit better, then actually it's an indication that they're going to benefit from having shunt. If we're thinking about the gait and balance impairments, I've got a couple of videos here, but I've got a slide around differential diagnosis coming up just in a moment, so I'll probably utilize them there. That's all right. There's a wide variety of symptoms are described with gait, but particularly, I guess, features we're thinking of an overall slowing in speed. The actual step height and step length are reduced, and we kind of get this shuffling type pattern with a widened base. And you'll also see described kind of externally rotated feet, so kind of a wide base, externally rotated feet. The patients also do tend to be quite retropulsive, so we would tend, I'll talk around with differential diagnosis with PD or other conditions, but often the patients will be quite extended, so almost that retropulsive upright posture. They'll struggle to respond to external cues to correct their pattern. So, verbal prompting for you to say, take longer steps that might be beneficial with other conditions won't be very helpful. And on block turning, so they can struggle with turning. That's quite common. And I have found some of these patients can struggle with dual tasking. I think probably not quite so selective just to normal pressure hydrocephalus that as a symptom, but sometimes quite useful to differentiate from other things as well. Often the speed will be a bit slower, even more so with dual tasking. But certainly a condition from what I normally find with these patients is they'll walk kind of how they walk. There might be things that can help a bit, but normally they can vary a little bit day to day, but their pattern will be their pattern. So not maybe such like Parkinson's or another condition which might, for example, improve with cubing, or maybe someone who has, maybe, I don't know, arthritic knees where they're stiff when they first get up, but then they find their walking gets easier over time. And I guess the other classic symptom of this condition will be it's generally something that's been gradually deteriorating over a period of time. So probably 3 to 6 months is what we kind of normally hear, sometimes a bit longer, but they've just noticed that things have been gradually a bit more difficult. If we're thinking about cognitive changes in normal pressure hydrocephalus, we do have a clinical psychologist as part of our service who does some bespoke assessments in relation to this. There is other symptoms that we can also see, but particularly things around slower information processing and executive function. So kind of that problem solving and flexible thinking would be kind of the two main symptoms we tend to see, and maybe that slower psychomotor speed as well. The patients can be a bit apathetic and sometimes have some issues with attention. And I mean, sometimes some of the patients can have some issues with their memory, but it's normally because they've had too much information and they haven't been able to process it. So this wouldn't be the type of patient that's just forgetting all of the names of grandchildren or keeps misplacing keys around the house. That may be suggestive of a different process than, or sometimes I guess maybe the MPH is really advanced. But normally these earlier stages is kind of these cardinal symptoms are particularly issues with executive function and information processing. So they're actually cognitively, other parts of their cognition is quite good, but just that processing speed is very slow. And urinary incontinence, we tend to say that this is again something that kind of progresses. Normally would start with kind of a degree of urge, but it can progress to absolute urinary incontinence and even fecal incontinence in the latter stages of the disease. When we're thinking about the presentation, lots of the papers will discuss around kind of motor being the first thing people see, and it tends to be motor, urinary, and then cognitive. And actually, even when after people have had their shunt, if they've been treated for it, that generally that progression and improvement would be in that order as well. That you tend to see motor first, then urinary and cognition. But there is some more research which is suggesting maybe some of the other features early, say of cognition, are a bit more subtle and people don't always recognize them, but maybe they are having some difficulties. So I want to talk a little bit more around differential diagnosis. I've got quite a nice video which I'll talk just a little around Parkinson's and normal pressure hydrocephalus, and then I've got a video I'll show you, and then we can come back to the other bits if that's okay. Particularly, as I said, the key things, I think, the difference between Parkinson's and normal pressure hydrocephalus. Parkinson's is probably the most common condition it will be mistaken for. Sometimes we know Parkinson's can have a bit of an asymmetrical presentation. So maybe someone who has just my right side is harder to use, or my right hand feels harder. And if you think about this etiology of normal pressure hydrocephalus, this slow buildup of the cerebral spinal fluid, it's just sitting in the ventricles globally. So you shouldn't have a unilateral deficit. So that would normally be something we'd be thinking of Parkinson's or another cause. You can sometimes see rigidity and bradykinesia in maybe more advanced normal pressure hydrocephalus symptoms, but again, I guess a resting tremor, freezing, like significant freezing episodes, or this bradykinesia and rigidity would be things we'd probably more be associating with Parkinson's than we would with normal pressure hydrocephalus. And the big thing I think around here is also around the base of support. So we tend to associate that Parkinson's with maybe that more kyphotic, flexed, and narrow base, whereas normal pressure hydrocephalus will be wider. So normally a wider base of support, externally rotated feet, and that more upward type posture as opposed to significant kyphosis. A few other bits just around other things, that often urinary incontinence is rare in early Parkinson's, and often that cognitive impairment is a bit rare in earlier stages of the disease. So whereas we can sometimes see them a bit sooner in normal pressure hydrocephalus. If I just see if I'll just bring the videos up here, because I think this is really nice. So this first video, move the bar. So this would be a very kind of classic normal pressure hydrocephalus type pattern. If I just move the chat, sorry, let me just move this. I'll just pause it and restart it and just move the chat bar up. Ooh. So then if you can see here where his base of support is quite wide, though he's quite extended and quite tall, but he's got this kind of short shuffled gait pattern. He does actually have a bit of a festination, so he kind of stops and catches his balance here. But he's quite tall and extended and very upright in his posture. And although he struggles with the initiation, that is a problem he's having, his pattern stays quite consistent once he's going. Now, if I just click off here, and I'll show you the Parkinson's one here. So do you see here immediately how that base of support is narrow and there's a different nature to that gait? So it's a little bit more flex, a little bit more kyphotic. So certainly that difference between that narrow base of support and that flex pattern. He does actually have I think on this video, he has a bit of a freezing episode here and gets a bit stuck. But that's that other classic symptom I was mentioning, how sometimes those Parkinson's patients, once they get going and move, their pattern quickens, or they can walk more easily once they've kind of cued and started, where we see that with normal crash hydrocephalus. I'll just show you the first video one more time. So again, a bit of a wider base, but he remains quite extended. Still those short shuffle pattern, but more upright. So upright, external rotated feet, and a wider base of support. Go back to so just considering kind of other conditions that can present similarly to this, there's PSP, or progressive supranuclear palsy. Early in that presentation of PSP, particularly cognitively, it can present quite similarly to normal pressure hydrocephalus. I guess within PSP, we might expect kind of a general slowing of movement. We might see that they have a particular posterior loss of balance. So I don't know if many of you've seen PSP patients, but the pull test, if you pull them backwards, they'll literally have no saving reactions. They'll just go backwards. They can also have quite a lot of axial rigidity, so really stiff, stuck necks. If you try and move them or their trunk, they're really very stiff. And further in the diagnosis of PSP, they talk about like a vertical gaze palsy. So any further movements upwards, they're unable to. And there's a applause sign as well, which can also be a sign of Parkinson's. So if they're clapping, you ask them to clap 3 to 4 times, they continue. They struggle to disinhibit that movement. Alzheimer's and cognitive impairment, or dementia. Again, there's lots of different types of this, but often with Alzheimer's, quite a cardinal symptom our psychologist talks about is issues with wayfinding. So, or particularly misplacing items as being something quite commonly she'd associate with early Alzheimer's presentations, and maybe not so much something we'd see in MPH, and also issues with episodic memory. So again, as we talked about, that the speed of processing being much more common and executive function problems being much more common in MPH, whereas this episodic memory might be associated with that. From a gait perspective, often as well, I found these patients will struggle more with the complexity of actually the task than actually being able to move. So even one of the tests we sometimes do will be the timed up and go. They may need reminders about the next stage of the task. They won't have retained it, or so generally the more of these gait issues might relate to the actual cognitive elements of it as opposed to kind of the motor part of it. I guess just considering other conditions that can influence these patients too. I mean, if someone is older, that maybe they've just got some associated age-related joint changes, maybe there's arthritis, so they've got a unilateral limp, or a really, actually a really very stiff leg, which is why they're having difficulties bringing it through. I guess other associated possible history. So just have they got a lot of conditions which are all influencing them a bit. Vestibulopathies, so problems with the vestibular system. I guess we might expect those patients to be a bit more visually reliant, or maybe particularly complaining of dizziness, maybe motion provoked symptoms, which again wouldn't be a common sign of normal pressure hydrocephalus. Maybe they've got kind of a TBI or previous stroke, other issues. So again, those more central signs we might expect to see with those conditions, things like, I guess, increased tone, maybe a very unilateral presentation, unilateral weakness. Not necessarily, we don't expect our patients to really present with central signs. And peripheral neuropathies. So again, maybe something we can quite commonly see, people who maybe have got numbness in their feet or associated distal motor problems. Generally with an MPH, we'd expect someone in sitting, or again, when the conditions progress more, we can see some sitting issues, but normally in sitting, they've actually got good limb movement in all 4 limbs, no particular problems. So again, might be a way of distinguishing, sensory assessment, looking at joint position sense. Ooh, sorry, just seems to have frozen a bit here. Just to mention a little bit around the Revert project, which is, as I said, I'm on secondment at the moment, hoping that our service is extended. We're just waiting to hear about funding beyond the end of the project. But this has been a 3-year project. I've only been involved for the last year, but looking at kind of improving the treatment of normal pressure hydrocephalus. And it's linked with with Addenbrookes Hospital and Cambridge University, and then hospitals and some institutions in France, with the idea of kind of sharing best practice and trying to develop and improve clinical care through sharing information, sharing expertise, and looking at developing novel diagnostic approaches to better diagnose this condition and diagnose it earlier. So particularly around things like the pressure contrast MRI, I spoke about, that's been something that's come out of there, and even the protocols for the infusion studies. That's also been something that's been developed through the project more. And we're looking at the assessment protocols and the things we do, sharing with the group in France, alongside actually maybe looking at wearables or apps that might also better help us be more objective in actually capturing change with our patients. At Addenbrookes, so just to talk a little bit around our service, we've got a multidisciplinary team we work with. So as I said, the patient's presentations, sometimes it can be a very tricky condition for us to diagnose, because actually sometimes we can see comorbidity as well. So someone may have a baseline diagnosis of Parkinson's, or we have seen some patients even with a baseline diagnosis of Alzheimer's who then actually have an overlay of normal pressure hydrocephalus. So actually that real close working with our specialist nurse, our neurosurgeon, and our neuropsychologist is really important. And we also have an infusion technician, so he would be responsible for doing kind of the infusion studies and helping to calculate those values. But actually our MDT, we always see patients at a joint initial clinic, but having those MDT discussions about presentations is really helpful. The idea, I think it's included on this one too. I'll talk about the process and our pathway in a moment. As I said, this is funded as part of this research project. So we're collecting patient data at the moment, trying to look at outcome and better differentially diagnose patients, and hopefully using that to support further developments in the future treatment of normal pressure hydrocephalus. Something we are also hoping to kind of do and look at working and building on is a role for more formal rehab after shunts. Normally this group of patients actually should get on quite well after shunt if it's, they've got we picked the right patient. But what we can find is they develop secondary compensation. So things that we will all be quite familiar with, reduced confidence, visual over-reliance, maybe fixing, being very anxious to turn. And often these things can actually they're the things that need the rehab. Generally, things with gait will gradually progress, normally after over a few weeks and months after the shunt surgery. But actually supporting people to be safe and develop that confidence, that's kind of, I think, where there is more of a formal role for physios in rehab, and kind of something we started doing a little bit of. So the treatment pathway, will receive referrals and the patients will get triaged into our one-stop clinic. So they'll come in normally for around 2 hours, but as part of that, they'll be assessed either by our specialist nurse or consultant, and then myself and our neuropsychologist. As part of that, so I'll do a full assessment, full impairment-based assessment, neurological assessment, and then also kind of an activity in gait screen, so looking at moving, transferring, balancing. We then also we complete some baseline outcome measures, so 10-meter walk test, the timed up and go, a timed 360-degree turn to both sides, and then a short falls efficacy scale, and then normally a formal balance measure, so either Tonetti or the Berg. We do a few of the variations of outcomes depending on how someone presents, so if they're higher level or lower level, but it just gives us a good baseline to know where someone is. And those actual full outcome measures will also complete at 3 months and 1 year after patients have been shunted. So it's a good way of actually seeing progress and change. If we feel like someone fits that clinical picture of normal pressure hydrocephalus, then the next stage of the assessment to kind of help the diagnosis would be the lumbar infusion study, as we'd mentioned. So alongside that, we do very kind of brief screening so brief assessments of gait and cognition before and about 2 to 4 hours after the lumbar infusion study and the TAP. The gait assessments are a timed up and go, a 10-meter walk test, and a 360-degree turn. So just a few less of the measures. The idea is they're quite quick. They're quick and easy to do. They can be completed by the members of the team. So it doesn't necessarily mean they can still be done when I'm on annual leave. And actually they capture other things around gait. So we talk around kind of gait speed, but I have noticed actually sometimes patients' gait speed doesn't necessarily change, but they will have a reduction in steps and a quickening time in turning, which will still be significant. So we're hoping to capture more things that are going on there. The other thing we can then do is an extended lumbar drain. So that would be someone being admitted for 3 to 5 days to then just drain a bit more CSF. So basically, instead of having a one-stop shop of CSF drainage, we can do it over a longer period of time and drain more to give, I guess, a more accurate result and an exaggerated result. The complication risk is a bit higher with this, and obviously with current NHS pressures, any longer hospital admissions can be tricky. They can be cancelled. And actually, one thing we are finding with our service being more objective is we're needing to do less of these extended lumbar drains, which I think hopefully is a good step forward. And it hopefully means that the service is a bit more streamlined. The shunt surgery, if patients have their operation, we'll normally kind of oversee them during their inpatient admission alongside our neurosciences team, and then they'll return to our clinic 3 months after surgery and 1 year after surgery for a bit of a follow-up. Normally guiding exercises, ongoing progression, and kind of seeing how they're getting on. Just briefly talk about shunt. Oh, actually, sorry, I've got one other little video to share. So just thought this is quite useful. So talking about shunt surgery, so this is just looking at a gentleman before and after surgery. And this is actually where I think this condition is really amazing. Some of the changes are really significant. We have had patients quite recently, a particular patient who basically was off legs. And actually after 2 weeks after a TAP, he was able to walk unaided again. So some of the improvements are a bit more subtle. And often I think if there's more past medical history, we can only treat the normal pressure hydrocephalus side of things, but changes can be quite significant. So this is the gentleman initially before his operation. So again, that kind of quite classic pattern, wide base, quite short and shuffled. Not quite as severe as the other gentleman, but you can see he's quite slow to turn. But if you do look, his feet are a bit externally rotated. A bit of that wider base. And then post-shunt surgery, I don't have the exact date for this, but I would imagine this is a few months down the line. But do you see how much quicker he is, how more even he is, how that base of support is much more narrow, how he's much more quick on turning? And even he doesn't really have that on-block turning pattern. He can kind of move his trunk and his head a bit quicker. And these are some of the changes we can see in clinic that we'll try and flag up to patients. Just close that one. So shunt is essentially a device which will remove, it's an implanted device which will remove the CSF from the ventricles to another area of the body where they can be reabsorbed. Often they'll go down into your tummy. They basically have 3 kind of main components. So an inflow part of the catheter, so which will be in the ventricles. Oh, sorry, let me go back on to full. Which will sit in the ventricles. The catheter then, the shunt then tends to sit just behind the ear, and then it has this valve mechanism which can basically be opened. It's normally magnetically controlled, and it can be adjusted, but it'll be open depending on how much actually CSF we want to drain. So normally it gets set at kind of an arbitrary level for most patients, and then that will be one of the things we sometimes do when patients come back in clinic. They may well adjust that up or down depending on how someone's been doing. And then the outflow catheter tends to run, generally it's fed under the skin. So kind of sit subcutaneously, and then, as I said, pass generally into the peritoneum, but they can pass to other areas depending on anatomical reasons. Sorry, I should move this up. So prognosis and follow-up. As I said, I showed that video just of actually some of the patients before and after. And that is one of those things, I would say, when we talk about the condition being reversible, I think if patients have had symptoms longer, what we tend to see is maybe the symptoms aren't completely reversible, as if they'd never had it, but actually that patients, the vast majority of patients will improve if we've treated the right patients. I do think that the presentation is probably, well, it is progressive because, as I said, the underlying cause is these vascular issues. So actually the shunt is helping the CSF reabsorption, but it's not necessarily reversing the underlying base vascular cause. But that's kind of one of the things where I guess we need more research looking in longer term outcomes. You can see here some of the literature that there's variations in the figures they're quoting. So up to 82% or even 91% of patients will notice an overall improvement at 12 months post-surgery. The figure is slightly lower in the study, in the Tumor et al., which was a systematic review, reporting 73% of patients still at 3 years will report significant improvement. And Jordan had suggested that patients will tend to get more improvements in gaits, or more patients will get improvement in gait than they will in cognitive function and maybe continence. But again, there's some varied reports in the literature. And I guess that's the other bit I'm quite interested in. There's a bit more research coming out also suggesting this targeted rehab, which as I said is it's a bit more focusing around kind of sensory motor, balance rehab, gait rehab, that can significantly also help patients post-operatively. Clicked off again. And I guess within our service in Cambridge, there is, to say about kind of the MPH services, there is specialist services across the country. So there's the National Hospital, there's a service down in Plymouth, there's one in Nottingham, there is a service in Liverpool, and our service in Cambridge. And that's kind of one of the other things I am trying to do as part of my job, is link the services up a bit. So we've got a bit more of a destination map for patients. Because we are a specialist service, we have had referrals from Rochdale. There's a patient we've had from, Rochdale up north, or we have had referrals from kind of the West Country as well. I think just patients have been recommended our service and referred in. So we're not kind of led by geographical barriers. For our kind of referral criteria, we if patients haven't got imaging, the normal referral pathway would be via GP into a neurologist, who'd normally request imaging, and then if they show dilatation, refer onto our service. But if someone has had imaging, so one of your patients, I guess, maybe has had a fall in a TBI, they can be referred directly into our consultant in our service and kind of come in that way. And actually, I guess since doing this job, we have had 2 or 3 referrals, which has been a therapist working with someone in the community, or maybe I had quite recently someone working on the wards at Addenbrookes. So physio, who's just actually was asking the question to the doctor, this presentation doesn't actually quite add up. Have we considered normal pressure hydrocephalus? Do you think that would be quite useful? And there's a patient actually currently listed for surgery who's one of those patients in. One of the other reasons, as I said, as part of our outreach with the project, we want to kind of help more people understand this condition, because I think at times we can be, as a physio, we may be the only person working with this patient who's maybe got a diagnosis of Parkinson's. They don't respond to medication. They're just under the physio. And I think sometimes actually we're kind of almost uniquely placed to be maybe spotting these symptoms maybe early, and maybe a condition that, often these patients are told there's nothing that can be done for their symptoms. They've got irreversible dementia, or they have, chronic issues with their continence, or they've got Parkinson's, which doesn't respond to medication, when actually there is sometimes a treatment because the diagnosis isn't quite correct. And we have some patients come or referred into our service, and actually when we assess them, we don't think it's normal pressure hydrocephalus. But actually, I guess what we're kind of hoping as part of our project is the more people are aware of this condition, the more referrals we can get, and actually the more patients we can help and treat for this condition. I will just put the post-survey, sorry, if I just go off very briefly, I'm about finished, but I will just put the brief post-survey questionnaire, post-teaching questionnaire in the chat box, if that's okay. Just copy that there. And I'm sorry, I've been, let me just get on here. If I just see if I can stop sharing my screen, if I can work out how to do that. How do I do that? I maximize this. Ooh. Sorry, I'm struggling with just at the end here.
You want to stop sharing, Toby? Do you want, I can
Yeah,
do that
could you do
for
that?
you.
Sorry,
Yeah,
didn't
no,
it?
that's all right. It's there we go.
And I'll just put the link just in the chat box here. So I can see that there are a few questions in the chat box. I'm obviously, as I said, very happy to answer questions, but maybe should we work through the chat box questions first, and then if anybody has any others, put a hand up and we can kind of work through them. Does that sound okay? And I guess just one more plug for the questionnaire. If people do just have 2 minutes to finish, click on that and complete that just before they log off today. I'll be very, 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 very grateful. Thank you.
Toby, just while people are having a chance to fill out the questionnaire, can I just say a huge thank you to you? That was so interesting, and I learned absolutely loads. You know, just when we met, when we were prepping this, you talked to me for 5 minutes and I'd already learned loads. And I feel like pH is something I've always just gone, oh yeah, maybe jotted it down in past medical history and really not thought about it. And I think I can imagine there's a lot of people that are having misdiagnoses, and I can imagine there's a lot of people we're seeing out there that we need to flag it up. And I found the stuff around differential diagnosis and the GATE videos really, really helpful. So just a huge thank you to you for coming out tonight to present to us all.
No problem. And I just say I'm really, really grateful for you giving me the opportunity to come and talk to you. As I said, it's kind of an area before I kind of started this secondment, I didn't know loads about myself. And I think actually I feel very passionate about it. When we see the results as well for some of the patients coming back, it's really amazing. And yeah, from my perspective, the more people can share this with, you know, the more people have a bit more understanding of it, then the better. The other thing I should say as well is I'm very happy, maybe Laura can work that out with you afterwards, but I'm happy to share my email as well. So if anybody did have any clinical queries about patients, anyone they were worried about, or just wanted to ask, very happy for people to have my email to message me. That's also absolutely fine. Perfect. Should we work through a couple of these questions? Does that sound?
Yeah. Do you want me to read them out, or do you want to just go for it?
Maybe. Just seeing as I'm not doing brilliantly well with Zoom, would you mind reading them out? Sorry.
So,
Laura, I don't know if my question really, I think you've kind of already answered it, Toby, those first couple of questions that I asked, to be honest. So, yeah, I don't think you need to dwell too much on them, Laura. Sorry.
And I mean, probably just in relation to those, the only other bits I'd add is like many of these conditions, we can't ever go just on imaging. So we do sometimes see patients who've got, you know, will have some degree of ventricular enlargement, but actually then they don't have any of the symptoms of normal pressure hydrocephalus. So actually then we don't necessarily treat someone just based on a scan. And like you kind of mentioned, global atrophy is something that can, you know, patients who've got significant global atrophy, their ventricles can appear a bit bigger. There is another sign called DESH, which is, I'm going to forget now, but disproportionate enhancement of the subarachnoid space. So these kind of basically around the ventricles, you'll see this, and that's often a sign they'll also look at or mention on scans as being something that kind of is associated with normal pressure hydrocephalus. But similarly as well, we sometimes have people when the ventricles are maybe a bit enlarged, but not as big as other patients, and then they do really well off the tap. So it's kind of almost something to maybe fit that picture. But generally, when we're trying to diagnose it, we're kind of looking at actually, does someone have symptoms? What are they describing? Does their imaging kind of maybe support that? But then actually the way for us to tell is we get them in for that infusion study and do a tap and see, you know, we do objective measures to actually see if there's significant change in function kind of before and after.
So there was also a question from Adrian about ventricular dilation, and he felt it seemed to be dismissed due to cerebral atrophy and not investigated further. I don't know if you've had any experience around that.
Yeah, so I think this can be something where and that kind of fits with that earlier question about comorbidity and co-diagnosis as well, but someone could have global atrophy and normal pressure hydrocephalus. They don't necessarily have to be exclusive diagnosis. On the flip of that, because someone's got maybe slightly enlarged ventricles, it doesn't necessarily mean they've got normal pressure hydrocephalus either. So I think probably in reference to that, I'd be, if you had a patient, I'd definitely be thinking about that clinical picture, particularly around those classic symptoms, that wider base, externally rotated feet, that degree of retropulsion. The thing I didn't mention as well is, and I had Bill Clark was asking me before this around kind of patients maybe who are more impaired, maybe at a sitting balance level, what we see. Because sometimes we have had patients through who are, maybe at a return level, or have had even patients who've been hoisted. And not normally from a trunk perspective, they'll be quite retropulsive in sitting. I know that's not necessarily brilliant to distinguish from other conditions, just let alone, but normally that retropulsion is something we see quite commonly. So, and actually, maybe someone who's just using standing, maybe just with a return or a frame, they tend to also have this wide base. So even within those presentations, which are a bit more advanced, you'd kind of be looking at those particular symptoms. And as I said, in the more advanced presentations, you can sometimes see some of this rigidity and stiffness, but again, maybe rigidity or those more firm neurological signs like clonus, it's not a classic symptom of MPH. So that may be where you're looking at an alternate diagnosis there.
Great, thank you. Questions are coming in thick and fast, so
Okay.
I'll crack through them. So question from Daisy, is there anything specific you work on with a patient from a prehab perspective, so prior to surgery?
I guess the nature of the condition, actually, your physio is not going to influence the CSF. So it's not to say that it's not important, but I guess I'd be focusing on anything I can do to keep my patient doing as much as they can. Often these patients might have more difficulties, as I said, when they're actually on their feet and moving, as opposed to when they are sitting. So I guess I'd be considering that payoff where maybe if someone is really struggling to mobilize, kind of the usual things we might think about is, your walking aids and those bits, but also really considering the role of seated exercise, that maybe if they're on that pathway to be treated, is there ways that they can still exercise to that level to manage those secondary changes we can see with joint range, connective tissue, cardiovascular, all of those things. So that would probably be my suggestion in reference to that, if that's helpful.
Great, thank you. We've had some similar questions to someone asking about what can we do whilst people are waiting, shunt surgery of poor mobility. Someone asked something about if there was any specific cues we can use. I think you mentioned cues don't work like with people with Parkinson's. Yeah,
so I mean, I'd say generally speaking, I'll kind of go back on my words a little bit in that sometimes with milder presentations, I have found some patients can, if they're reminded, just take bigger steps. They can manage to do slightly bigger steps. But generally, if it's a more, the more significant presentations, things like queuing wouldn't be quite so effective. So yeah, I guess queuing probably wouldn't be my first go-to strategy, but it's not to say that's not a useful thing to explore, because actually I have had patients through in our clinic who do brilliantly with queuing, but then even actually with that, then often I'm going back through their presentation and working out if this is completely MPH as well. So it's I think that part of it is quite useful. Yeah, so I think that's probably what I would say in reference to that.
And then someone's in a similar place because there's a patient with query MPH and they're awaiting neurologist, but there's a bit of a waiting list. So they've asked if there's, you've talked about mobility already, but is there anything else that, we as physios could support them with relation to falls, cognition, continence while they're waiting a review?
Yeah, so I guess I'd definitely be thinking around, because maybe these patients will struggle to adjust their pattern appropriately. It may be thinking about those things you would often do around walking aids to look at kind of optimizing their base of support a bit, and actually see if maybe that makes them feel a little bit more confident that they can do it a bit more. If the patients can be quite retropulsive, so we don't obviously want everyone flexed over a frame, but sometimes these patients can do quite nicely even with some of the amended like gutter type frames as well, which just brings them forward a bit but keeps them a bit more upright. I sometimes don't find patients do brilliantly with walking sticks, and I think just because they're quite extended and quite retropulsive already, it can be almost something to get in the way a bit more. I guess the other things around education too. So I've had quite a few patients where even their walking's not terrible, but they really struggle on turning. So actually even part of that, making sure that their family actually know that's something they find difficult. Maybe there is some strategies or environmental things we can change that can help with that a little bit. One other feature we do see with a lot of patients is visual over-reliance, which I think is a secondary symptom to lots of things. I used to do in my old job in neuro outpatients, a lot of work for vestibular patients who would be very visually reliant. So often actually looking at exploring balance and particularly kind of removing visual cues. So kind of multifactorial balance like that can be quite a nice way to something else nice to work on too. That actually even before their surgery, they can be trying to work on optimizing their balance. So almost another bit of a prehab too. And I think, as I said, just thinking outside the box a bit of how to exercise patients too. So if they can't do those normal things in standing, you know, actually there is still a good role for seated exercise and maybe making sure they understand that too. And I wonder as well, I mean, that's the only thing, depends on area where you are, but if you're having real difficulty with getting patients into an MPH service, maybe also someone to message me about too, and I'll see what I can suggest. I do find with this patient group that maybe someone who's had a fall, they sometimes have a CT head as part of their, you know, admission to A&E 3-4 months previous, which actually for our service would be fine for us to accept the referral. So even if it's that I can give some advice or, you know, signpost to the appropriate local service, maybe someone to contact, then, you know, also happy to help with that.
Thank you. And this leads on to kind of referral pathways. Someone spoke about, so if someone's had a neurologist review, would the local neurologist look at referring straight to services similar to you, or would they start managing it in the hospital with a lumbar tap locally and follow up? That's what they found in their previous experience.
Yes, I think it is a bit like anything, these things in the NHS, it can vary a bit area to area. The services we're kind of a bit more linked in, I think normally the actual shunt treatment is looked after by a neurosurgeon, but that's not to say that that's exclusively. And I know we have had a few referrals where neurologists have got someone in to do taps, you know, they brought someone in for a tap. So I think that does vary a little bit locally. I guess if you're the therapist working with the patient, maybe even just having some liaison with the neurologist, you know, that might be quite a useful way so you know what they're going to do, because sometimes in other services, neurologists will see a patient right back to the GP who then has to refer somewhere else. So it can be a bit clunky sometimes. So I guess just understanding where someone is on that pathway and what's going on is important. But as I said, I think most of the services, so say like the National Hospital, our service, and I think the services across in Bristol and Plymouth, I'm pretty sure that's under neurosurgery. But yeah, I don't think that's necessarily exclusively like that everywhere.
Thanks. Sorry, this question's coming in. I've got to
You're
move
fine.
my up. I've lost where I was. Okay. So someone asked about whether there's an upper age limit for surgery. Also thinking about people living with frailty. So a lot of her patients are frail and 85 plus and often deemed unfit for surgical procedures.
So, I mean, I'd say I think our consultant with this is quite pragmatic. There's not an age limit that they'll have as a cutoff for patients. I guess with all surgery, they would look at a pros and cons type approach. But I'd say actually, I think our consultant's very keen to do something if they can, and he feels it will help, which is a bit not necessarily dependent on how old someone is or if they have a pre-existing diagnosis. The thing to bear in mind, I guess, is someone's got more significant past medical history or more things affecting them, is maybe if normal pressure hydrocephalus is only 10% of their presentation, a shunt will help with that 10% of the presentation, but we won't be able to reverse the other 90%, maybe related to those other conditions. So maybe sometimes in those situations, they they might wonder if, not to operate at that time. But I know, generally speaking, if we're going to offer surgery, our surgeon will normally talk those things through, but age wouldn't be a reason we wouldn't see someone. And yeah, I guess frailer patients, we get some frail patients through our service too. We do have like a pre-assessment service for any surgical candidates, so they'll look at kind of trying to optimize things like nutrition and other bits like that pre-operatively, so we have the best outcome. In reference to surgery, the actual shunt, it's normally quite a quick admission. So generally, we try and aim for our patients to be out of hospital within 1 or 2 days. And actually, shunt surgery is only, the operation's about an hour. So it's, in the grand scheme of neurosurgery, it's quite a small operation. So it doesn't mean it's not without risk, but I think from that regard, it's a little less risky than maybe some other big surgeries, which is probably also a positive.
Great, thank you. So another question, how common is it for people's symptoms not to improve significantly after shunting? And if we were seeing someone for rehab following a shunt and felt their presentation really wasn't improving, what would we do? How quickly should we refer back, etc.?
Yeah, so I mean, like, I think quite a lot of the literature is that we were talking about prognosis, they were tending to, some of the figures are around 80 to 90%. And I think I'd probably say with the patients I've seen, like, we're still a bit in the process of collecting our post-shunt data, but with the data we've collected, probably seeing around that figure, probably more nearer to 90%. So patients generally improve, but maybe we do have some who don't improve quite so significantly. I guess if you felt like there was almost that the presentation was still very MPH, even though they'd had their shunt, is I'd have a relatively low threshold for contacting either the neurologist or the neurosurgeon back, because sometimes patients can have a shunt, but you can sometimes have shunts that malfunction. We actually had a patient in quite recently where the shunt at the top here on all scans looked fine, and actually the distal catheter had dislodged in the tummy, so it wasn't draining, and actually the patient had got worse. And as I said, they will make shunt adjustments. So sometimes we have patients come back in our clinic at 3 months where they haven't significantly changed that much, and actually we wonder if the shunt's under draining a bit. So they will sometimes do like a shunt adjustment, so just open the shunt a bit further. And as I said, that's magnetic, so it's our specialist nurse and our consultant do it, but it's not an overly complex thing to do. And so we'll monitor the patients. So I'd say if you feel it's still an MPH presentation, then it wouldn't be the worst thing contacting the doctors back and kind of just explaining your reasoning why you feel concerned.
Great, thank you. Had a couple of people that have said that they've got patients with MPH who have been advised shunting wouldn't help, and just interested, I know you talked about kind of risk benefits of surgery. Are there any other kind of key contraindications to shunting?
It's probably something better discussed with my consultant, but I generally would, I think, around kind of those normal bits with, I guess, past medical history and that relative frailty, or I guess, I mean, I'd probably be thinking about significant disease burden. So as I said, we have had a few patients through who've maybe got quite advanced Alzheimer's, and actually they maybe haven't changed that much when we've done the tap, or that actually their Alzheimer's and cognitive impairment was so advanced, we didn't really feel there'd be much benefit from, and maybe gait problems weren't quite so significant. Or there was another patient through who had very, I talked about progressive supranuclear palsy, but had a very PSP type presentation. He had quite big ventricles, so we wonder if he had some overlying pressure hydrocephalus, but he didn't really change. And we again wonder that actually his progressive supranuclear palsy seemed quite significant. So I guess it's maybe that those are often the things I'd be thinking about, like gross disease burden, maybe other past medical history. But yeah, I'm trying to think of other particular contraindications. I mean, I'm not sure about other particular contraindications, why they wouldn't, but I'm sure there is a few. It's something I can always ask and find out if you'd like me to have a word with my consultant next week.
Thank you. And then someone asking about is there a strong evidence around the 2 to 4 hour time frame between retesting gait after people have a lumbar tap?
Yeah, so there's varied evidence. I mean, in best practice, there's been a few Japanese studies where they get patients to come back into the hospital. They do the post measures 2 to 4 hours after the tap, and then get patients to come back into hospital for every day for a week or every day for 5 days. And actually, obviously, quite a lot of our patients, we're in Cambridge, but quite a lot of our patients are from out of area. So in Norfolk, Suffolk, Bedfordshire, Hertfordshire, sometimes even a few hours away. It's just not pragmatic to be able to bring patients back in regularly. So the other thing we do as part of our service is we give patients a questionnaire to complete at 1, 3, and 7 days after they've had the tap, to just basically rate their symptoms and comments. So the idea is then our consultant or our specialist nurse will phone the patient up after this period when they've got all the results and actually ask the patient how they've got on, because there is a group of patients where they improve maybe a couple of days after the tap. So I'd say it's not completely foolproof, but actually within what we can offer, and I guess pragmatically, you know, already maybe someone's in, then having to wait around for 2 hours to be assessed. I think 2 to 4 hours is a bit of a best fit. And I guess we are seeing quite a proportion of patients will improve after that time. So I think with what we've got at the moment, we probably capture a reasonable proportion of patients, but there is evidence, as I said, to suggest probably best practice is maybe getting people in 1, 3, you know, for these repeated objective assessments several days afterwards as well.
Thank you. And then Alison's shared a personal story which really highlights the importance of raising awareness, and I hope she doesn't mind. I'm just going to read it out because I think it's really powerful. So she said, I know from personal experience how important it is to share, sorry, chat box is jumping around, to share knowledge about this little known condition so it can be picked up early. Unfortunately, I had little awareness until my father was diagnosed last year. Sadly, it was not picked up early enough, and hospital-acquired infections and pressure sore meant he lost any chance of treatment. He was a fit and able man, and I was shocked how suddenly he lost his mobility. I'm experienced community physio, but was unable to help. It's so important we pick this up as early as possible. So huge thanks to Alison for sharing that personal story, and just really kind of, it just shows how important these sessions are that you're running, Toby. So sorry, moving on from there. I just didn't want to leave it till the end and run out of time and miss reading that out. Okay, so another question. Patient has been putting off his shunt adjustment, as he said he's had 2 out of 3 done. Is there a limit to adjustments?
No. So from my understanding, I don't, would depend on the type of shunt, but I think it can be adjusted a number of times. So sometimes we'll have had patients where they'll tinker it up and then tinker it back down again, depending on symptoms. So generally not from my understanding.
Thank you. And then I know you talked about, you know, all surgery has risks, but do you see many adverse effects post-shunt? Someone had a patient that had a stroke after having a shunt and just wondered whether it was possibly related.
From the patients I've seen, as I said, I've only been kind of more formally in the service since July, but I haven't seen, I think of all of our patient group, probably haven't seen anybody with more adverse, like significant adverse effects. I mean, I'm sure, I know as part of the preoperative, pre-op checks, they talk about relative risk of stroke because they have to stop, they'll have to stop certain medications in order for operation to go ahead. So particularly like blood thinning medications, so that there is probably a small chance of increased risk. The other thing I guess we can see, it would be, you know, your classic kind of hospital-acquired infections or post-op deliriums. That tends to, from the patients I've seen, that tends to be a bit more common maybe with patients with baseline cognitive impairments or difficulties before than our milder patients. The shunt patients, as opposed to, from what I've seen, as opposed to the patients who have the tap, where some of the changes can be quite instant, shunt patients sometimes will leave the hospital quite similarly as when they came in, and actually the change in progress happens over those weeks and months after they go home. Yeah, so I'm not sure I kind of answered that question, I think.
And then what if someone isn't appropriate for a shunt? How are they advised to manage their condition? Is there anything physios can do from an ongoing perspective to support people?
So I guess those management strategies we talked about earlier, particularly kind of, I think, considering ways that maybe someone can exercise, being safe in walking as much as is possible, and just understanding their problems involving their loved ones. But then I guess considering alternate ways they can exercise as well. So maybe seated exercise, other forms of that. And just to say as well, I just talked mostly around shunt, which would be the common surgery. There is other operations they do sometimes do. So things like ventriculostomy, which would be actually opening up the ventricles themselves. Normally that might be if someone's got more of a secondary problem, but there is other operations sometimes as well. But I guess we do know if it is MPH, and we can't treat it, or we don't treat it, it is a condition we would expect to slowly progress over time. So I guess the physio can help. And sorry, the other thing I would definitely be thinking about is trying to identify and manage kind of visual over-reliance as well, particularly in standing, if that's a symptom somebody has. Even maybe in sitting, if we know someone who tends to be a bit more retropulsive, maybe looking at strategies that not to be leaning back quite so much, or some stretching. But yeah, I guess if it is MPH, we probably would expect it to slowly increase over time if it's not treated with a shunt. But it isn't to say that like supportive physio doesn't have a role there.
Thank you. And sorry, the questions are jumping from people that are for shunt and aren't for shunt. So someone asked, when someone's had a shunt, are there any contraindications or guidance we have to know about from a physio perspective?
Not masses. I think normally the guidance we have from our end is they avoid kind of heavy lifting up to kind of a week post-operatively, just because of where the distal catheter goes into the tummy. Other than that, normally not too many contraindications. They would advise people not to drive for 6 months post-shunt, which is quite normal kind of neurosurgical advice. But yeah, I guess kind of maybe like lots of early vigorous exercise I'd probably avoid in the first few weeks after surgery. And I said normally these patients will do quite well. They'll kind of gradually improve without loads and loads of input. So I guess trying to find ways that encouraging someone to be a bit more active and finding ways to kind of support that wouldn't be a bad idea. Yeah, I think probably then, I don't know if it's an exclusive contraindication, but as I said, probably in reference to the tummy, avoiding too much trunk work, early sit-ups, stuff like that, probably is a bit advised, at least for those first few weeks after surgery.
Great, thank you. I think this might be the final actual question.
Okay.
So if anyone's got a burning question, quickly type it in the box.
That's fine.
Oh, look, no, another one's coming already. Sorry. Okay, is there any possibility of over drainage post-shunt? And do you see any symptoms related to that?
Yeah, so that can happen. As I said, normally with the shunt, they'll set it at kind of a midline setting. And normally with the understanding that they probably will open it up a bit more if they can, the first clinic appointment. But you can get over drainage. Normally the cardinal sign of over drainage is headaches, like quite severe headaches, which will be relatively constant. So if someone does have them, then that's worth like flagging that up, because you can get over drainage. You can also develop, if you had really bad over drainage, you can get like secondary subdural collections. So basically things get sucked in a bit too much and you can get secondary subdural collections. So I guess headaches, I mean, you're probably unlikely to see secondary weakness with subdurals and be a bit more of an emergency situation, but definitely severe headaches, which seem to associate with a, relatively unrelenting and seem to associate with maybe shunt adjustment. Yeah, definitely that is something we do see sometimes.
Great, thank you. And I think this might be the final question. How long should the shunt last for? Will patients need other follow-up after the 12 months?
So generally my understanding is kind of once a shunt's in, I don't necessarily know it's got like a particular lifespan. So often the kind of post-operative management, if things have gone fine, will then just be normally a bit of a shunt adjustment in that kind of opening the valve a bit more. They'll basically want it to be as open as possible to drain as much as you can in order to manage someone's symptoms. But then generally we do sometimes get patients who've had shunts in, in the early 2000s who might come back in for a shunt adjustment. Sometimes people can get kind of shunt infections many years down the line. So I guess if someone's got odd symptoms, that would be something they'd be aware of as well. But yeah, not once someone's had a shunt, not necessarily anything else they might need to do. As I said, probably the only thing thinking about like longer term management for someone after a shunt is the underlying causes of this condition MPH we think are vascular. So although I work for a project, the REVERT project is called the Reversible Dementia Project. That's kind of the caveat to that, is that actually we may expect sometimes some symptoms in the longer term, 5 or 10 years, to maybe slowly progress, just because a shunt can kind of treat the main symptom. It can't necessarily reverse the underlying etiology of the condition. But sometimes that may be where, like, making sure the shunt is draining optimally can be something we can do about it. And actually, I guess more widely thinking about vascular factors, having someone fit and active as possible is going to help their vascular health, which is probably another big role of ours in that patient group.
Great, thank you. And just in case you don't see them in the chat box, Toby, loads of compliments about how brilliant the session was and how people can apply what they've learned to their daily practice, and it's raised their awareness, etc. So I just wanted to say again, a huge thank you. Thank you for everyone coming to listen this evening, and thank you, Toby, for your excellent presentation and answering a barrage of questions. I felt like you were a consultant neurologist and a physio.
No, I know. Putting me through my paces, getting your money's worth. And then
if people haven't already filled out your post-teaching questionnaire, if people could do that, that would be great. We have recorded it tonight and it will be on our Agile YouTube channel. I will probably have to watch it back to take in some of it again, to be honest with you. So that resource will be available for everyone.
And yeah, just to say thank you so much everyone for having me. It's been really great. It's been really brilliant to be able to talk to you all. And I'll share, if that's okay, or I'll share with you my email. I'm very happy for that to be sent out. If anybody wants to message me, and if anyone can just complete the survey afterwards as well, very grateful. And I'll try and get on to sorting and adding I apologize again to anyone from Scotland, Wales or the Isle of Man. I'll rejig my questionnaire so you can complete it.
Great, thanks again, Toby, and have a lovely evening, everybody.
Thank you.